When you take your car to the mechanic and they hand you that itemized bill, you can usually parse what is actually going on.
Right, yeah, like a busted alternator or a leaking fuel line. It makes intuitive sense.
Exactly. You are dealing with a machine and, the parts are broken.
Mm-hmm.
But then you get your own medical chart after a doctor's visit, or maybe you read the discharge papers for a family member, and suddenly you are not looking at a machine anymore.
No, not at all.
You are looking at a dense wall of ancient Greek.
And it creates this profound sense of alienation for patients, I think. We naturally crave that same mechanical clarity for our bodies, especially when we are vulnerable.
Yeah.
But instead, you are handed these highly opaque, multi-syllable terms that honestly, they feel intentionally designed to keep you out of the loop.
Which is exactly what we are fixing today. Welcome to a brand new deep dive. We are taking a stack of clinical neurology guidelines, historical medical archives, and modern diagnostic criteria to decode the secret language of the nervous system.
It's going to be...
Yeah, our mission today is laser focused on 3 high-yield medical suffixes. We're looking at esthesia, paresis, and kinesia. And I promise you, this is not just about memorizing some vocabulary flashcard.
Far from it. I mean, understanding these 3 suffixes is really about unlocking how the human body actually feels and moves at a mechanical level.
Right. And by the end of our time today, you are going to be able to effortlessly parse dozens of those intimidating terms on your own medical paperwork. You will understand exactly how doctors communicate when the nervous system starts to break down.
Absolutely.
But to really grasp that, we have to establish the biological foundation of the nervous system first, right? Like before we get into the historical narrative surrounding these specific words.
Yeah, we have to draw a clear distinction between the 2 distinct directions information travels in your body.
The up and the down.
Exactly. We need to establish the divide between the afferent pathways and the efferent pathways.
Okay, so afferent first.
All right. Afferent refers to the ascending sensory pathways. So this is information traveling from your fingertips, your skin, your internal organs, moving up the spinal cord and ascending into the brain for processing.
Like sensory input going in.
Yes. And then afferent refers to the descending motor commands. That is the brain generating a signal, sending it down the spinal cord and out to the muscles to actually execute a physical action.
Okay, let's unpack this. Is it accurate to say the nervous system operates like a city's electrical infrastructure?
I like that. Let's see.
So esthesia is the afferent sensory grid, right? It's the system reporting a power outage in a specific neighborhood back to headquarters.
Right.
Then on the efferent side, paresis is the city's generator actually losing its brute force, like the power is physically draining.
Mm-hmm.
And a kinesia is the motor of a machine acting erratically, like twitching or slowing down, even if the raw power itself is fully turned on.
I think that captures the mechanics perfectly, yeah. And if we connect this to the bigger picture, keeping that infrastructure straight in a clinical setting dictates the entire trajectory of a patient's care.
Because they're completely different problems.
Exactly. If a clinician conflates a loss of raw strength with a loss of motor control, or confuses an ascending sensory failure with a descending motor problem, the diagnosis is fundamentally flawed. The words dictate the reality of the treatment path.
Which sets us up perfectly for our first suffix, esthesia.
Right.
It derives from the Greek aesthesis,
Yeah.
referring to sensation or perception. This is entirely on that afferent ascending sensory side we just talked about.
The incoming signals?
Yeah. It is your capacity to perceive touch, temperature, pain, and pressure. And by attaching different prefixes to it, you can map out almost the entire spectrum of human sensory malfunction.
You really can. So you have hyposthesia, which is a dulling or reduction in sensation.
Like a numbness.
Yeah. And then you have hyperesthesia, where the nervous system amplifies sensory input, which results in a heightened, often painful sensitivity to normal stimuli.
Everything's turned up to 11.
Exactly. Then you have paresthesia. The prefix part implies something abnormal or alongside the usual.
Okay, what does that feel like?
This is that classic distorted tingling, the pins and needles sensation you get when you sit on your foot for too long.
Oh, man, yeah. And reading through our clinical sources, there is a massive misconception about paresthesia out there. Because it sounds like this severe permanent medical condition, people panic when they see it on a chart.
They do. They assume it implies permanent nerve death. But in reality, most paresthesia is transient.
Right.
It happens because physical pressure temporarily restricts the blood flow to a peripheral nerve, which disrupts its ability to fire those afferent signals to the brain.
So the nerve is just kind of starved for a minute.
Yes. And once the pressure is relieved, The blood flow returns, the nerve membrane repolarizes, and normal sensation resumes. Now, persistent paresthesia can certainly indicate pathology, like the demyelination seen in multiple sclerosis or peripheral neuropathy from diabetes.
Sure.
But the suffix itself simply describes the sensory state. It doesn't inherently dictate a grim prognosis.
Okay, good to know. Then there is dysesthesia, where dys signifies something bad or painful.
Right.
This is when the sensory pathways are so scrambled that a completely harmless stimulus, like a soft shirt touching the skin or just a light breeze, triggers a severe burning or agonizing sensation. The brain is misinterpreting non-painful input as tissue damage.
It's awful for the patients.
I can imagine. But the term that anchored an entire medical revolution, I mean, the one everyone listening has definitely encountered, is anesthesia.
And meaning without.
The total absence of sensation
Right.
and the ability to intentionally induce that state represents one of the most profound paradigm shifts in human history.
Oh, absolutely. The modern medical currency of aesthesia really traces back to a single, incredibly well-documented event on October 16th, 1846.
The famous ether dome at Massachusetts General Hospital.
Yes. A dentist named William T.G. Morton administered inhaled sulfuric ether to a patient named Edward Gilbert Abbott right in front of a surgical amphitheater,
Just a live audience.
a live audience, and a prominent surgeon, John Collins Warren, then excised a vascular tumor from Abbott's neck.
Wow.
Before this moment, surgery was an agonizing, traumatic race against the clock. It often required multiple people to physically restrain a screaming patient.
It's so barbaric to think about.
And Abbott remained quiet. He felt no significant pain.
And Warren famously turned to the stunned audience of medical professionals and said, "Gentlemen, this is no humbug."
Yeah,
He knew instantly that the brutal era of surgery was over.
he really did.
But I was looking through these historical archives, and I found it fascinating that the word anesthesia wasn't actually coined by Morton or Warren, the guys in the room.
No, it wasn't.
It was coined weeks later by Oliver Wendell Holmes Sr.
A physician and writer who wasn't even part of the surgical team.
Right.
But he recognized the gravity of what had happened and wrote a letter to Morton suggesting they needed standardized, dignified terminology for this phenomenon. He proposed anesthesia for the physical state and anesthetic for the agent causing it.
It was a brilliant linguistic intervention, honestly, and it stuck globally.
It did.
But the clinical reality of that word has evolved drastically since 1846. Back in the ether dome, they were just achieving a profound numbness and stupor. Today, general anesthesia isn't just, putting someone to sleep. That's a massive oversimplification.
Oh, huge. Modern general anesthesia is a highly orchestrated physiological tightrope walk.
Yeah.
An anesthesiologist is actively juggling 5 distinct states simultaneously.
5.
Yeah. Unconsciousness, which is the lack of awareness. Amnesia, preventing the brain from consolidating memories of the trauma. Analgesia, which is the actual blunting of pain signals.
I think that's 3.
Then the suppression of autonomic stress reflexes, keeping the heart rate and blood pressure from spiking when the scalpel cuts. And crucially, akinesia, which is total physical immobility.
And they achieve that immobility not with the unconsciousness drugs, but usually through completely separate paralytic agents, right?
That is the key mechanism. They use neuromuscular blocking agents that selectively paralyze the skeletal muscles. This stops those efferent motor commands from reaching the muscle fibers, while entirely separate anesthetic gases or intravenous drugs target the brain to maintain unconsciousness.
Here's where it gets really interesting and honestly profoundly terrifying. The phenomenon of anesthesia awareness.
It is the ultimate clinical failure of these independent systems.
Right, because the anesthesiologist is titrating those drugs independently. If the paralytic drug working on the efferent side completely succeeds, you have that akinesia, you cannot move a muscle, you cannot blink.
Exactly.
But if the specific drug maintaining the unconsciousness fails or metabolizes too quickly, the patient wakes up. The afferent sensory pathways are wide open, registering the pain of the surgery, but the descending motor pathways are chemically severed. You are awake, in agony, and completely unable to signal the surgical team.
It is a genuinely traumatic collision of these biological systems. The intended anesthesia, the loss of sensation, fails, while the iatrogenic or drug-induced akinesia holds strong.
That is just a nightmare.
It's important to note this is exceedingly rare today, but the horrifying emotional and psychological weight of that possibility is exactly what drove the development of intraoperative brain monitoring technology.
Okay.
Yeah, anesthesiologists now use processed EEG devices to monitor the actual electrical activity of the cerebral cortex. We learned we cannot simply rely on a lack of movement to guarantee a lack of consciousness.
Wow. So anesthesia awareness traps a conscious mind inside a paralyzed body. But what happens when the sensory pathways are perfectly fine and it's the descending motor commands that hit a structural roadblock?
That brings us to our second suffix, paresis, from the Greek word meaning a letting go or a slackening. We are crossing firmly into the efferent motor side now.
And the most vital misconception to clear up for anyone reading a medical chart is that Vedas paresis does not mean paralysis.
No, not at all. Total paralysis uses a different suffix entirely. That's maija, derived from the Greek word for a stroke or a heavy blow. So hemiplegia denotes the complete, absolute loss of voluntary motor function on one vertical half of the body.
Total loss.
Right. Hemiparesis, on the other hand, describes partial weakness on one side. The efferent motor power is diminished, it is slackening, but the pathway is not completely abolished.
And clinicians rely on that distinction every single day. Writing evet paresis instead of eclesia communicates a vastly different level of structural damage. We see this heavily emphasized in the FAST campaign for stroke awareness. Face drooping, arm weakness, speech difficulty, time to call emergency services.
Yes.
That sudden arm weakness, that is acute hemiparesis.
When an ischemic stroke occurs, a blood clot blocks oxygen to the motor cortex or its descending pathways. Brain tissue begins to die rapidly.
Right.
However, depending on the location of the clot, some corticospinal fibers often survive the initial ischemia. That survival of some pathways is what results in partial weakness, the hemiparesis, rather than total hemiplegia.
So it's a critical window.
Exactly. Recognizing that specific paresis symptom is the catalyst for immediate intervention. Administering clot-busting drugs can restore blood flow and salvage the dying brain tissue.
But the historical application of the word paresis is incredibly messy.
Very messy.
It entered clinical neurology in the mid-19th century. Silas Weir Mitchell, a prominent American neurologist, popularized it while treating Civil War soldiers who had suffered horrific gunshot wounds to their peripheral nerves. He needed a precise term to systematically describe the partial motor loss he was observing.
And he established its valid neurological use. Unfortunately, the term was subsequently co-opted by psychiatry in the late 19th century, resulting in one of the most historically dramatic misuses of medical vocabulary on record.
The terrifying diagnosis of general paresis of the insane.
Right. Also referred to in the literature as dementia paralytica. This was a progressive, horrifying syndrome that accounted for a massive percentage of asylum admissions across Europe and North America.
And how did it present?
Well, it began with dramatic personality changes. Patients exhibiting delusions of grandiosity, severe cognitive decline, erratic behavior, but it invariably progressed to intense physical weakness, wasting, and eventually death.
And for decades, the medical establishment debated the root cause. They attributed this terrifying decline to moral failings, to a weak constitution, or simply to the overstimulation of modern urban life.
What's fascinating here is how the choice of terminology obscured the reality of the disease.
How so?
By anchoring the diagnosis with the word paresis, they were describing merely the late-stage physical weakness while completely missing the systemic mechanism driving the illness. It was firmly categorized as a psychiatric or moral failing.
Right.
It wasn't until 1913 that a brilliant Japanese-born researcher named Hideo Noguchi, working at the Rockefeller Institute, completely shifted the paradigm.
What did he find?
He examined the brain tissue of these deceased patients and found a specific bacterium, the Syphilis spirochete, embedded directly within the brain parenchyma.
So what does this all mean? We slapped a clinical label for muscle weakness onto a systemic, sexually transmitted bacterial infection, effectively blaming the patients for decades simply because our microscopes weren't powerful enough to see the bugs eating away at their brain tissue.
That is the tragic reality of medical history, yeah. General paresis was, in fact, tertiary neurosyphilis.
Wow.
The syphilis bacteria, often contracted years or even decades prior and lying dormant, slowly invaded and degraded the central nervous system. The personality changes and the subsequent motor weakness were the mechanical result of infectious brain damage.
Unbelievable.
And once penicillin was mass-produced in the 1940s, this massive, terrifying psychiatric diagnosis essentially vanished from asylums almost overnight.
It's a stark reminder that a suffix describing a physical symptom can mask a massive systemic failure. But what happens when the raw strength is perfectly intact? When the muscle can generate force, but the brain loses the ability to dictate the speed, flow, and coordination of the movement.
That brings us to our final suffix, kinesia,
Okay, let's get into it.
derived from the Greek for movement. While paresis evaluates the brute force of a muscle, kinesia evaluates the quality, speed, and intentionality of the movement.
You see terms like bradykinesia, which refers to abnormally slow movement. Akinesia, the complete absence or delayed initiation of movement. Hyperkinesia, which covers excessive involuntary movements.
Yeah.
And dyskinesia, those distorted involuntary writhing motions that a patient simply cannot suppress. And looking at our sources, you cannot discuss akinesia without discussing Parkinson's disease.
No, you really can't. James Parkinson published an essay on the shaking palsy in 1817. He detailed the clinical presentation of 6 individuals, some of whom he merely observed walking the streets of London.
What?
He documented the stooped posture, the resting tremor, and a very distinctive poverty of voluntary movement.
Parkinson himself didn't use the specific term bradykinesia, though. That arrived later when modern neurology required highly rigorous diagnostic criteria. And this is a crucial takeaway from the clinical guidelines we reviewed. If you look at the widely adopted UK Parkinson's Disease Society Brain Bank criteria, bradykinesia is absolutely mandatory for a Parkinson's diagnosis.
Yep.
The resting tremor is not.
And that surprises many patients. The cultural association with Parkinson's is almost entirely focused on the tremor.
Right, everyone thinks of the shaking.
But roughly a quarter of Parkinson's patients never develop a resting tremor. However, every single one of them develops bradykinesia.
And we should clarify the mechanism there, because it's not just moving in slow motion. The clinical hallmark is a specific decrement pattern.
Exactly. When a neurologist assesses bradykinesia, they ask the patient to perform a repetitive motion, like repeatedly tapping their index finger and thumb together as wide and fast as possible. A patient with Parkinson's might initiate the movement normally, but with each successive repetition, the movement becomes progressively smaller in amplitude and slower in speed. The mechanical signal degrading over time, that decrement, is the defining feature.
But disorders of kinesia are not exclusively caused by neurodegenerative diseases like Parkinson's. We also have to examine the profound medical irony of iatrogenic or drug-induced movement disorders, specifically the paradox of dyskinesia.
Right. In the 1950s, the introduction of the first generation of typical antipsychotic drugs, such as chlorpromazine, revolutionized the treatment of schizophrenia. They were miraculous for managing psychosis.
But there was a catch.
A massive one. Over years of use, clinicians observed a devastating delayed side effect in patients on long-term treatment.
A delayed effect, meaning tardive, stemming from the Latin word for slow or late appearing, tardive dyskinesia.
Yeah. These patients began exhibiting involuntary, repetitive movements like lip smacking, tongue protrusion, facial grimacing, and coriform movements of the limbs.
That's heartbreaking.
The tragedy was the underlying mechanism. These antipsychotics functioned by blocking dopamine receptors in the brain. Over time, the brain responds to this blockade by upregulating those receptors, making them hypersensitive. Even if the medication was discontinued, the writhing movements often persisted permanently.
It was a sobering era for psychiatry, realizing a treatment could induce a permanent, highly visible movement disorder. And it wasn't until 2017 that the FDA approved valbenazine, the first drug specifically targeting this mechanism.
Yes.
But then you have levodopa-induced dyskinesia, which presents with very similar writhing movements, but occurs for the exact opposite pharmacological reason.
It's quite the paradox. Parkinson's disease is caused by the death of dopamine-producing neurons. To treat it, patients take levodopa, a precursor drug that the brain converts into dopamine to replace what is lost.
Okay, so adding dopamine instead of blocking it.
Exactly. But over years of treatment, flooding the brain with these fluctuating spikes of replacement dopamine overstimulates the remaining receptors. So you have the exact same suffix dyskinesia, the same involuntary writhing mechanical distortion caused on one hand by blocking dopamine and on the other hand by forcefully replacing it.
The suffix merely names the resulting symptom pattern. It tells you nothing about the underlying mechanism. I want to make sure we distinguish this from two neighboring concepts that often confuse patients reading their charts. First, ataxia, like ataxia.
Right. Ataxia translates to a loss of order or coordination. It indicates pathology in the cerebellum, the brain's coordination center, rather than the motor cortex.
So it's not a strength issue.
No, not at all. A patient experiencing ataxia might possess completely normal strength, so they have no paresis and normal speed of movement, no bradykinesia. But when they reach out to grab a cup of coffee, their hand overshoots or misses the target entirely because the complex sequencing of the movement is disorganized.
Got it. And the second distinction is akathisia, derived from a pen plus capesis, literally translating to not sitting. This is an intense, subjective inner restlessness. It's a notoriously distressing side effect of many psychiatric medications. To make sure the mechanics of this are clear, if we look at dyskinesia like a puppet with tangled strings, the limbs are jerking around involuntarily because the descending motor commands are scrambled.
Yes.
But akathisia isn't a string problem at all. It's the puppet itself experiencing an agonizing psychological drive to pace the floor. Am I thinking about that right?
That is an excellent way to visualize the difference. Dyskinesia is a mechanical, efferent distortion of the physical movement itself. Akathisia is a profound psychological distress, a sensation that demands movement for temporary relief.
That's a crucial difference.
Conflating the two clinically is a dangerous error because unrecognized akathisia carries a high risk of escalating agitation, impulsivity, and even severe self-harm.
Wow. We have covered a tremendous amount of clinical ground today. We established the fundamental afferent sensory grid of esthesia, tracing it back to the ether dome where Oliver Wendell Holmes Sr. gave a name to the deliberate suppression of human sensation.
Yep.
We crossed over to the efferent motor strength of paresis, exploring how it triggers immediate stroke protocols today, while serving as a stark reminder of how general paresis masked the bacterial reality of neurosyphilis for decades.
It's wild to think about.
And we concluded with the efferent motor control of kinesia, unpacking the specific decrement pattern of Parkinson's and the pharmacological paradox of treatments causing the very writhing movements they seek to suppress. Gaining fluency in these three suffixes doesn't just demystify a medical chart.
No, it really doesn't.
It fundamentally empowers you to understand emergency triage, to advocate for the quality of your care, and to accurately weigh the risks of informed consent.
This raises an important question, something we haven't touched on yet from our clinical notes, but which feels deeply relevant to our discussion of medical history.
Okay, what's that?
There is a fierce, ongoing debate right now in modern neurology regarding patients who present with severe dysesthesia and paresthesia, but have no clear structural cause.
Oh, right. These are patients reporting intense burning, tingling, or agonizing crawling sensations. But when clinicians run an MRI or conduct standard electromyography nerve tests, they can't find a single visible lesion, pinched nerve, or demyelination event.
And historically, the medical establishment's response to these patients has been incredibly dismissive. Because the structural damage couldn't be visualized on standard imaging, the afferent sensations were often minimized.
Just brushed off.
Patients, predominantly women, were historically labeled hysterical or told the pain was entirely psychogenic.
It is the exact same intellectual trap as the 19th century asylum doctors. We blamed general paresis on moral failings simply because our microscopes couldn't yet see the syphilis bacteria.
Precisely. Fortunately, modern neurology is developing a much more sophisticated view. We are now mapping conditions like small fiber neuropathy, where the damage occurs in microscopic unmyelinated nerve endings that standard nerve conduction studies simply cannot detect.
Oh, wow.
We are also understanding central sensitization, where the brain's processing of pain signals becomes hyperactive, which is common in conditions like fibromyalgia. These are legitimate, biologically grounded mechanisms for profound sensory symptoms that were actively doubted for decades.
So if our modern medical vocabulary relies so heavily on visible structural evidence to legitimize a suffix, to prove to the clinician that the aesthesia is real, how many other genuine, agonizing physical sensations are we casually dismissing today simply because our diagnostic technology hasn't caught up to the reality of the patient's experience?
It is a humbling thought for any clinician to sit with and a vital piece of context for every patient navigating the healthcare system.
A perfect place to leave it. The terminology is powerful, but is only a map of the territory. It is never the territory itself. Thank you so much for joining us on this deep dive. We'll see you next time.